Welcome everyone, and thank you for joining us. My name is Alana Heckler, and it is my pleasure to welcome you to the first episode of the Nephrology webinar series, hosted by the EUROIMMUN Academy. We are excited to present today's topic, the role of PLA2R and other biomarkers in the diagnosis of membranous nephropathy. Following the presentation, we will open up the webinar for a Q&A session. If you have any questions for our speaker at any time, please type them in the chat box on your screen, and we will relay them at the end of the talk. Without further ado, it is my pleasure to introduce you to our speaker, Dr. Laurence Beck. Dr. Beck is an Associate Professor of Medicine and Director of the Glomerular Disease Center at Boston University School of Medicine. He graduated from Harvard University in 2000 with a dual MD-PhD degree and completed his internal medicine residency and nephrology fellowship at Boston Medical Center. Dr. Beck completed his research fellowship in the lab of Dr. David Salant, where together they identified the major autoantigen in human membranous nephropathy as the M-type phospholipase A2 receptor, PLA2R, in 2009. This landmark finding and subsequent publications from Dr. Beck have brought insight into the pathogenesis of membranous nephropathy, as well as the clinical use of anti-PLA2R antibody testing for the diagnosis and monitoring of the disease. Dr. Beck's research has also led to the discovery of an additional autoantigen in membranous nephropathy, Th-7a, and the identification of LRP2 as the target antigen in anti-brush border disease. Dr. Beck, we are honored to have you here today to discuss the role of PLA2R in more detail. And with that, I will hand it over to you to begin your presentation.
So the topic today will be the role of anti-PLA2R and other biomarkers in the diagnosis of membranous nephropathy. And I'm going to break it into several sections. I'll first start just with a brief introduction to the nephrotic syndrome and to membranous nephropathy. Then I'll talk about the autoantibodies in membranous nephropathy, both in terms of their pathophysiology, but also their clinical utility. I'll discuss the evolution of our guidelines for the diagnosis and monitoring of membranous nephropathy. And finally, I'll end with a little bit about the treatment of primary disease. So the cell type that I fell in love with, and that is the topic of this talk and many discussions about the nephrotic syndrome, is the podocyte. So the podocyte is an epithelial cell. It sits on the outside of the capillaries in the glomerulus, and it provides, through its primary, secondary, tertiary processes, the final barrier to protein loss. So the slit diaphragms and the glomerular filtration barrier typically keep protein within the lumen of the blood vessel in the body. But when podocytes, schematically in this green blob here, become sick, they lose that fine architecture, their foot processes and the slit diaphragms, and they become more of a simplified cell type without this glomerular filtration barrier. And instead of protein being reflected back into the capillary lumen, protein can leak between the cells and end up in the urine. And the injuries can be intrinsic stresses. We've learned a lot about genetic causes of FSGS and metabolic causes, but they can also be extrinsic stresses such as cytokines, and in this case, autoantibodies. So what is the nephrotic syndrome? Many of you who are clinicians have seen patients with this. Generally, the patients have volume overload, sodium excess that leads to tissue edema. If I pressed my finger into this person's foot, I could leave an indentation. There's a lot of proteinuria, and patients may often complain that their urine is very bubbly or foaming, as seen here. If you look at the urine under the microscope, you'll often find evidence of fat droplets within hyaline casts, these fatty casts. Oval fat bodies are also epithelial cells that are engorged in lipid droplets. You can find them in the urine. Occasionally, you can even see cholesterol crystals. But the other features of the nephrotic syndrome that you find in laboratory values are hypoalbuminemia and hyperlipidemia. So as a quick preface to the case I'll talk about today, this will be a 25-year-old male who comes to the emergency room complaining of left-sided flank pain, but in the course of his workup, he's found to have 3+ proteinuria and normal kidney function, and he's diagnosed with the nephrotic syndrome. So the question is, what is the cause of the nephrotic syndrome in this particular patient? And if you think about the general teachings, we think about primary disease. Typically, the primary causes of nephrotic syndrome are minimal change disease, FSGS or focal and segmental glomerular sclerosis, and membranous nephropathy. You may add in certain nephritic conditions such as IgA nephropathy, C3 glomerulopathy that can lead to heavy proteinuria. And then you think about the secondary causes. So diabetes, advanced diabetes can cause nephrotic syndrome, lupus nephritis, especially class 5, hepatitis B or C can cause either membranous nephropathy or MPGN. Amyloidosis is a rarer cause, and certain malignancies can be associated with nephrotic syndrome. Now, when I say FSGS or membranous nephropathy, this is actually a pattern of disease seen under the microscope by the pathologist. So there are many types of FSGS. We'll learn that there are different types of membranous nephropathy. Similarly, MPGN has immunoglobulin causes, complement-related causes, and crescentic GN can be Anti-Gbm, can be ANCA, etc. So these are just patterns. If you look at the breakdown by age, and this is a quick schematic from the Nephrotic Syndrome Study Network cohort, the Neptune cohort, that looks at these main diagnoses by age. And you can see in younger children, membranous nephropathy in green is very rare, but you do find the minimal change disease, you find FSGS. And as the cohort gets older, you're finding more membranous nephropathy, less minimal change disease, et cetera. So it really, the age of the patient makes one consider what diagnosis you might be more likely to be thinking about. And of all of these, the only one that really you can send a blood test for and find whether or not there's primary disease is membranous nephropathy, and that's going to be the topic for today. So what is membranous nephropathy? It's a leading cause of nephrotic syndrome in adults. It's a kidney disease that's mediated by autoantibodies, and the majority of the forms, maybe 75%, is what used to be called idiopathic, but we now call primary disease. It's an autoimmune disease that targets specifically the kidney, specifically the podocytes, the glomerulus. And the course is hard to predict. Patients can variably go into remission. They can have persistent nephrotic syndrome. If it is heavy nephrotic syndrome that persists for years, that can lead to end-stage kidney disease. And if a patient is transplanted, the membranous nephropathy can recur in the allograft. I'll mention the secondary causes. The main ones we see in the United States are lupus, class 5 lupus nephritis, hepatitis B, certain solid tumors, and drugs such as nonsteroidals. There's another class that we call alloimmune, where the body's immune system is reacting to a foreign protein. This can happen in mothers who are deficient in neutral endopeptidase and during pregnancy are exposed by the parental gene and can lead to membranous nephropathy in the infant. And then there's the de novo type of post-transplant membranous nephropathy that can occur due to sort of mixing and matching of different HLA molecules or other proteins. The natural history, one thing that becomes very important for this discussion is that it's a very slow onset compared to, say, minimal change disease, which a child may show up, a week later and have weight gain, periorbital edema, leg edema, et cetera. Similarly, primary FSGS can come on in a more explosive manner. When a patient comes into the clinic with membranous nephropathy, they're often complaining of weight gain, leg edema that's occurred slowly. They may notice the foaming of the urine. And generally, 75% of patients or so are nephrotic when they present. Another 25% may be subnephrotic. And some of those may progress to the full nephrotic syndrome. We talk about the rule of thirds in membranous nephropathy, that a third will undergo spontaneous remission on their own, a third will remain proteinuric but have stable renal function, and a third will progress towards end-stage kidney disease. And again, like the onset of disease, the resolution is slow. So you don't expect after treatment the patient to be back to normal proteinuria a month later. It often takes months to years. So this is what you might see if your renal pathologist detects membranous nephropathy by light microscopy, and this is a PAS stain. You see these thickened capillary loops that are due to these deposits that form within the capillary loops. If you do a Jones methenamine silver stain, if you look closely, you can see tiny little spikes, and this is the extracellular matrix that's deposited around the deposits, and then the lucencies or pits or craters, and this is because the immune deposits don't stain well with silver. When you do the typical immunofluorescence for IgG or complement factor 3, you see this fine granular pattern of deposits in the peripheral capillary loops. And when you go in even further and look at electron microscopy, this is a podocyte looking quite sick with some microvillous projections and loss of slit diaphragms and foot processes. But you see these electron-dense deposits, and this is what is the sort of the immune deposits of membranous nephropathy, sitting right below the podocyte in a subepithelial position. So what is in these deposits? And this is another image by electron microscopy. And the important thing for this discussion is that there's antibodies, there's IgG, and there's an antigen. There's also complement components, which probably are mediating the damage to the cell. And when I came along and started my research in David Salant's lab at Boston University, the question still hadn't been answered. Are there antibodies in patient serum, patients with membranous nephropathy, that react specifically with some protein found in the human glomerulus? And if so, what is that protein? So in the diseased patient, autoimmune disease turns on for some reason, probably genetic inheritance, environmental triggers, but these antibodies go into the kidney, they target the glomerulus, and they cause this pattern we know as membranous nephropathy. We exploited that by taking serum from patients with membranous nephropathy or other nephrotic disorders such as FSGS or diabetes and asked, is there a common protein, and this is done by Western blotting, is there a common protein that's recognized by antibodies from patients with membranous but not these others? And it turns out that there was about 180 kilodalton protein. When we blotted normal human glomerular proteins. But the question is, what is this protein? And it took another year and a half or so working with our collaborators at the University of Louisville to figure out what this was. And it turns out that this particular protein turns out to be a podocyte protein. We didn't know it at the time, but the M-type phospholipase A2 receptor. It's a transmembrane protein. The bulk of it sits on the outside of the podocyte with 10 domains, and we now know that in at least 4 of these domains, there are targets, epitopic targets for the antibodies. And it's a normal protein in the podocyte. In this immunostaining image, the glomerular basement membrane is stained in green, and sitting outside of that in the urinary space are these red stained podocytes, and the red stain is detecting PLA2R in the normal podocyte. So what we think is happening in disease, and a lot of this is based on rat models called heminephritis that were established in 1959, but a lot of work was done in the 1980s. We think that these antibodies cross from the blood, cross the GBM, find their target, so in this case PLA2R, cause clustering and shedding of the antigen and antibodies into these subepithelial immune deposits, where complement is activated. The terminal complement component, C5b39, punch holes in the podocytes, lets in calcium. There's a lot of maladaptive signaling processes. And more recent data suggests that the C3a and C5a anaphylatoxins can also target their cognate receptors on the podocyte that cause other injuries in the cell. I think the big point that the finding of this antigen created for the field of nephrology was that we now had something we could follow in the blood. So prior to the description of PLA2R and antibodies to PLA2R, we treated patients and we followed patients clinically. We measured their level of proteinuria, we looked at their kidney function, we assessed by their proteinuria and edema whether they were going into remission. And there were algorithms, which I'll present, that allowed us to make these decisions of who needs treatment. So once we found antibodies, and I'll use them interchangeably as anti-PLA2R or PLA2R antibodies in this talk, once we had something to follow in the bloodstream, we could add this serologic approach following antibody titer and trajectory to our monitoring and allow us to make perhaps better, but certainly more quicker decisions of who needs treatment and sort of do we need to change treatment, can we stop treatment? And most recently, this past fall, the Kdgo, the Kidney Disease Improving Global Outcomes, it's an international guidelines for kidney disease, published their clinical practice guidelines for glomerular diseases. And the Membranous Nephropathy chapter highlights how we can use these anti-PLA2R antibodies, and I'll discuss that as well. So there are two ways we can diagnose PLA2R-associated membranous. One, as I mentioned, is with these blood samples and serologic tests for anti-PLA2R. The other is by the old standard way, taking a kidney biopsy and doing the pathologic analysis and staining for PLA2R. The immunoassays currently available are Western blot that's mostly used in research. There's a newer chemiluminescent assay that's being developed, but the two clinically available ones are the cell-based indirect immunofluorescence test and the Elisa, and I'll talk about those. The benefits are that these are non-invasive. I guess I would say the downside is that you only detect the circulating antibody when it's there. If it's already gone away, you don't have a sense that this patient might have had PLA2R-associated disease. The complement to that is, as I mentioned, taking the biopsy, and in addition to staining for IgG and C3, you can stain for particular antigens, in this case PLA2R, and you'll get that same granular deposit if PLA2R is present in those deposits. The good thing about this is it detects, the deposits stay there for months to years. So if a patient is already in remission but has these deposits, you could figure out that they were PLA2R associated. It doesn't assess activity. So the presence of PLA2R in the deposits doesn't mean that that patient is still serologically or immunologically active. And this would be a typical stain. Both of these panels, the one on the left and the one on the right, have membranous nephropathy. This particular one is PLA2R associated. You know that because when the pathologist stains with commercial anti-PLA2R antibodies, you get the similar pattern to C3, to IgG in the peripheral capillary loops. This patient, even though there are deposits there, the deposits don't contain PLA2R. So when you stain with a commercial antibody, you don't detect PLA2R, and this haze in the background is the normal PLA2R within the podocytes. The commercially available assays, and both of these are FDA cleared, are the Elisa, in which case microtiter plates are coated. These red triangles represent PLA2R. And you add the patient serum at a dilution of 1 to 100, and you're asking how many antibodies are in this patient's samples that react with PLA2R. So you can get a titer of how much human anti-PLA2R is there. And negative is clearly under 2. The manufacturer's recommendations say that under 14 is negative, 14 to 20 is borderline, and over 20 is positive. And others have tried to come up with, what is a low titer, what's a moderate titer, what's high. I think that's a little bit arbitrary, and following directionality of changes is more important for a particular patient. But that's what is out there. Another more sensitive test is called many things, the IFA test, the indirect immunofluorescence test, cell-based assay. But this one involves microchips, and they are coated with cells, either parental 293 cells that don't express any antigens of interest, or ones that have been transfected, in this case with PLA2R, and you're asking, when you put the patient's serum on these chips, is there specific binding to the PLA2R and no specific binding to these parental cells? So this is also a very good and specific test for the presence of anti-PLA2R. Now I need to mention, and I think I've hinted at this, that there's more than one type of membranous nephropathy. We've talked about primary, the autoimmune type, versus secondary. And these can be autoimmune, but more systemic autoimmunity, such as systemic lupus erythematosus, infections such as hepatitis B, NSAIDs or other drugs, and malignancies. But also the adult forms and the rarer forms of membranous nephropathy that occur in children. We can break membranous nephropathy down by the dominant target antigen, PLA2R, or non-PLA2R type membranous nephropathy. And when you have that, you ask, is there a known antigen? And I'll talk about the explosion of antigens we've had in the recent years, or is it a still unknown antigen, something remaining to be found? Another way to think about this, and this becomes important when thinking about the sensitivity of the anti-PLA2R test, is there's the whole collection, the whole universe of membranous nephropathy as defined by the presence of subepithelial deposits on kidney pathology. That could be primary, which is about 75%. That could be secondary, the other 25%. In primary disease, the bulk of that will be PLA2R associated. And then there's non-PLA2R, but also likely primary. This may be some of the other antigens we'll talk about in the later slides. And even when we're talking about PLA2R type, not all of that will be serologically active. So only about 80% or so will have antibodies at the time of testing. Some of those others, probably the majority of those others, will have already gone into immunologic remission. So when you think about, what is the sensitivity of the anti-PLA2R test, you have to consider what the denominator is, right? Are you talking all primary disease? Are you talking about known PLA2R type? Are you talking about all membranous in general? And that will really go from 50% sensitivities to 80, 90% sensitivity, just depending on the denominator. And the reason for that is there are two disease courses, is the way I think about it. There's the standard clinical course, and that's shown by here in this dotted blue line that's detected by the amount of protein in the urine. But now we can detect the immunologic or serologic course, and that's this red trapezoid, where we're measuring titers of anti-PLA2R. And I think the good thing about this testing is that the immunological or serological changes precede and predict the clinical courses. So a patient may have, initially when they don't have autoimmunity, they'll have no antibodies. But once their B cells start making anti-PLA2R, you'll have low levels going to high levels. Either that patient will go into spontaneous remission, or they'll be treated, their levels go from high to low to negative. But it takes a little longer for the proteinuria to go away. So the proteinuria lags at the start, and then after the antibodies disappear, the proteinuria will either disappear completely to a complete remission, less than 0.3 grams per day, or will go to a partial remission, less than 3.5 grams. Patients may stay there if they have underlying scarring, or they may continue to go on to a complete remission. The important part is there are times, typically at the end of disease, where a patient will be seronegative, but if you look at their biopsy, they'll be PLA2R positive. So that tells you that these patients have probably gone into an immunologic remission already. Now, some people have tried to use the levels of PLA2R as sort of prognostic indicators, and I think there's some validity to this, in that when a patient has a high level, cross-sectional studies have shown that those patients are least likely to enter remission in any given follow-up. They're more likely to double their creatinine. This is because they're in the midst of active disease. It takes time for the antibodies to disappear and then the proteinuria to disappear. Versus someone who has low levels of anti-PLA2R, they're most likely at the end of the disease, and they will enter both immunologic remission sooner and clinical remission sooner. Why do I say they're most likely at the end? Well, you could have low levels of anti-PLA2R over here. And there are a few case reports of that, and you check them a few months later and they have higher levels. But these patients don't come to clinical attention. They don't have much proteinuria, so no one is really, they have no reason to come to the doctors. So the majority of patients will be at the end of their disease course when they have lower levels. And thinking about it pathophysiologically, again, we don't find these patients, but these first two images at the left are from a patient who has recurrent membranous nephropathy. And very early after transplant, this person went into transplant with circulating anti-PLA2R antibodies. A few weeks later, proteinuria developed. We did a biopsy, and there were these tiny, tiny deposits sitting right under the slit diaphragms. Over time, it was difficult to treat this patient using rituximab. The deposits persisted. They went from these stage 0 tiny deposits to stage 1, to stage 2, where there's extracellular matrix between the deposits. This was about a year later. The deposits were bigger, the proteinuria was bigger. So we base a lot of what we think is going on in the native kidney on our experiences in recurrent disease. But we do know in the native kidney that deposits can grow from stage 2 to stage 3, where they're completely surrounded by basement membrane, to stage 4, where something starts to resorb these deposits. They become more electron lucent. And this is a sign of recovering disease. But this all takes time, right? Again, this is the picture of this very injured podocyte with these huge subepithelial deposits sitting beneath it. You can just imagine, however that process takes place, how these deposits are cleared, how the podocyte goes back to having some semblance of the normal substructure with these foot processes and the slit diaphragms. Definitely months, probably years, and the basement membrane is probably still abnormal, even after the podocyte can reestablish its normal cytoarchitecture. So putting this all together in a schematic, we have anti-PLA2R that either spontaneously or with treatment declines and disappears. Until you reach some sort of threshold, you're still going to have these deposits forming. And then when you get either the anti-PLA2R clears or you get below some threshold, the podocyte or the endothelium or the mesangium can start resorbing these deposits. They become stage 4. The podocytes can try to regain their morphology. The proteinuria goes back to nadir levels, complete or partial remission. And if you're looking at the proportion of patients in a study that are achieving remission, it's going to occur 6 months out, 12 months out, 24 months out. This is what we see from our clinical trials. And this is why it takes such a long time to achieve partial and complete remissions. And we know this. We knew this early on after finding PLA2R as the target antigen. Fernando Fervenzo, Dan Catran, in their studies, their pilot studies using rituximab to treat membranous nephropathy, sent us some of their collected samples, serum samples from patients who had been treated, baseline, 3 months afterwards, 6 months, 9 months, etc. And we ran Western blots on all these patients. We realized that in many cases, this is PLA2R, so we're looking at anti-PLA2R. Their titers, levels of anti-PLA2R, declined and disappeared on average by about 9 months. And if we plotted each particular patient, we see in red, anti-PLA2R starts at 100%, comes down, disappears by 12 months. But the proteinuria took a little bit longer to go from its baseline down to the nadir level. So in aggregate, at 9 months when patients had cleared their anti-PLA2R, patients were still nephrotic, 4 or 5 grams, and continued to go down after that point. So this is why we could come up with this diagram talking about immunologic disease, immunological remission, clinical disease as defined by proteinuria, and predict that changes in anti-PLA2R titer would basically predict changes in proteinuria at a later time point. This is not just true for rituximab-treated patients. Elian Hacha and the group in Hamburg, Germany, very nicely showed that the standard treatments at the time, alkylating agents, the modified Ponticelli regimen with alternating months of cyclophosphamide and corticosteroids, would also very nicely drop anti-PLA2R, and this is using the ELISA. By 3 months, most patients had a dramatic decline that persisted through 24 months, but it took a little longer for that proteinuria to go down. Calcineurin inhibitors, which are also widely used and have their own anti-proteinuric effects, the anti-PLA2R came down a little bit, a lot of variability, which I think we still see in clinical practice, that there's more of a variable response on anti-PLA2R, but the proteinuria did come down and eventually decline. So let's go back to our case. and I'll give you more details. So this is a 25-year-old man who came to our emergency room with left-sided flank pain. He was found to have 3+ proteinuria, normal renal function, and the nephrology consult came and diagnosed nephrotic syndrome based on 8 grams of protein by urinary protein creatinine ratio. The serum albumin was 1.9, very low. And a kidney biopsy was set up at the time, but had to be canceled because in the interim, that patient complained of severe right-sided chest pain and shortness of breath, and was found to have a right pleural effusion and a large right lower lobe pulmonary embolism on CTPA. And likely this left-sided flank pain was due to a renal vein thrombosis, which might have then embolized to the lung, causing the sequelae. So we were referred for help in the clinic for help with diagnosis and treatment. And on examination, he was mildly hypertensive. On exam, he had right basilar rales, he had clear 2+ pitting edema, and urinalysis confirmed the 3+ albuminuria. He also had trace blood in his urine dipstick. That is common. That doesn't mean he has the nephritic syndrome. You can have trace or 1+ hematuria with the nephrotic syndrome. We didn't see any casts at that time. So the assessment was this young man had new onset nephrotic syndrome with venous thromboembolic disease and a pulmonary embolism, but we couldn't easily do a kidney biopsy because of his active anticoagulation with warfarin. So this brings us back to the differential and what we could potentially test for with routine serologies. So we sent complement level C3, C4. We sent for hepatitis and HIV serologies, which were negative. He had a negative anti-nuclear antibody. We sent immunofixation, unlikely in a younger male, but he had normal SIFE and SPEP. And we sent anti-PLA2R levels. It turns out he has a positive titer of 72 relative units per mil, and he had a positive indirect immunofluorescence test. So the diagnosis became PLA2R-associated membranous nephropathy. So this is typical now of the workup of heavily proteinuric patients to order an anti-PLA2R. You may ask, don't we need a kidney biopsy to make this diagnosis? How can we do this just by serologies? So it turns out that the first it's not a recommendation, it's a guideline, expert opinion that they call practice points in the Kdgo guidelines. The first practice point says a kidney biopsy is not required to confirm a diagnosis in membranous nephropathy if a patient is nephrotic and has a positive anti-PLA2R test. So the first step would be to check for anti-PLA2R. If it's absent, probably you have to go on to biopsy, and that's the patient individual risk. Our patient may not have opted for that given his anticoagulation, but in many cases you'll move on to biopsy. If you find anti-PLA2R, there can still be situations where that you'd be prompted to do a biopsy. So if you have a rapid drop in GFR, if you have other possible secondary causes, if the patient's not responding to your therapy, definitely get a biopsy. If the patient is normal, has normal kidney function, and you're not planning immunosuppressive therapy at the time, then you sort of have your serologic diagnosis. If you are planning immunosuppressive therapy, and this is what ended up happening in our patient, then you have to think about patient-specific factors. Does the patient have a solitary kidney? Are they on active anticoagulation? And weigh the risk of biopsy with the risks of the treatment you're considering. So again, what is a non-invasive diagnosis? Well, there are a few papers out on this, both with lead author Shane Bobart from the Mayo Clinic. The second one was a validation study. But the prerequisites for this is that your patient does have nephrotic syndrome or proteinuria. Most of the patients in the study did have nephrotic range proteinuria. That their eGFR is preserved greater than 60 in this study, that they don't have any secondary causes that a biopsy might be better to help tease out, so diabetes or other factors traditionally associated. And the ones they used in their studies were the possibility of lupus with lupus serologies, hepatitis, complement, and then screening for medications and cancers. And you want to have what I'll say a clearly positive anti-PLA2R test by Elisa or the IIFT. The Kdgo also has a practice point of what else should be considered for screening for secondary causes. And they mentioned that this is irregardless of whether or not they have circulating autoantibodies. So obviously you're going to get the full history, you can get a good exam, ask about drugs they might be taking like ibuprofen or other NSAIDs, general screening for age-appropriate cancer screening, chest x-ray, I would say more for cancer, but if your patient is hypercalcemic and has elevated 125 vitamin hydroxy D, then maybe sarcoidosis, which is a secondary cause of membranous. You could look for hilar adenopathy. And then in the United States, we generally would look, in a smoker, maybe do a high-res CT, chest x-ray to look for lung malignancies, iron deficiency. Is that patient up to date on their GI colonoscopy screening? For women, breast cancer, cervical cancer, et cetera, PSAs. The practice point mentions, and I haven't brought this up yet, anti-Thf-7a antibodies. What are these? So this was the second antigen found 5 years later in collaboration with the Hamburg group, Rolf Stahl, Nicolas Thomas, and Gerard Lambeau in Nice. Thf-7a is another podocyte antigen, and patients will often, have either mutually exclusive anti-PLA2R antibodies or anti-Thf-7a. There are rare cases, maybe between 10 and 15 have been reported in the worldwide literature that can have both anti-PLA2R and anti-Thf-7a. So think about it, but it's very rare. And the same thing happens. Antibodies to Thf-7a find their target in the glomerulus. They form these subepithelial deposits, and if you stain for IgG4 or IgG in general and Thf-7a, they perfectly co-localize. Both of them are in the deposits. We don't use anti-Thf-7a much. There's no clinically available ELISA. There is an IIFT, so you can diagnose it serologically. This particular study, was based out of Gerard Lambeau's lab, where they set up a research ELISA for Thf-7a antibodies. And you can see that patients with active disease have the highest levels. Patients who have reached complete remission have the lowest. And if you look at 2 time points, either in patients who are treated for their membranous nephropathy or who achieve spontaneous remission, those who go from high levels down to low levels are those that are going from active disease to remission. If you keep having high levels, you remain in active disease. So the same thing we'll see occurs for anti-PLA2R levels. So those were the first 2. And then in the past, say, 3 years, we started finding a lot more. And by we, I mean Sanjeev Sethi at the Mayo Clinic. The old way, the way that we in this laboratory, as I mentioned, we took patient serum, we looked for reactivity on Western blot with podocyte antigens, and it took a while to go from a positive band, and we screened all these other antigens before we found PLA2R. What's done these days is laser capture microdissection and mass spec of the tissue. This is what was going on at the Mayo Clinic and allowed Sanjeev Sethi and his group to find exhaustocin 1 and 2, NEL1, semaphore 3B, and a few others since then. You're just looking for what protein is enriched in these deposits that's not present in other cases of membranous nephropathy. So we, Nori Hayashi, a visiting researcher from Japan who worked with me in the lab, and I wrote an editorial on the finding of semaphore 3B, and we call this Moore's Law for membranous nephropathy. And analogous to how more and more transistors could be fit on a computer chip, leading to more and more computing power, that was what Moore's Law described. We saw the same thing happening with antigens in membranous nephropathy, first PLA2R, Thf-7a, and then this explosion identified by laser capture microdissection. So this was the latest one that our laboratory helped find, with Laith Al-Rabadi from Utah as the first author on the paper. But serine protease HTRI1 is a very rare target antigen in some patients with membranous nephropathy. This is a patient with this disease. Their biopsy is stained for HTRI1. You can see that the HTRI1 co-localizes with IgG, forming this orangey yellow deposits. Whereas if you have a patient with PLA2R associated who has PLA2R in these deposits, when you stain with a commercial anti-HTRI1 antibody, you don't get staining. So you could have a panel of stains that a renal pathologist could look for all these antigens. We're still working to see what the most efficient workflow is for renal pathology, but we're finding more and more of these, and they are discoverable by renal pathology. Many of these will probably have circulating antibodies that will correlate with disease course. These are in 2 patients with anti-HTRI1 type disease, and you can see their levels by Western blot fluctuate, and that corresponds to what's going on clinically. In this particular patient, their anti-HTRI1 levels declined and disappeared, and the urine protein dropped to undetectable, and their serum albumin went up. So this was the pie chart was the state of the art when a fellow, Lula Alsharan, and I wrote a core curriculum for AJKD, graphing it as a predominant primary form of PLA2R associated secondary autoimmune and all these other new ones. Since that was published, many more have been found, several that have seemed to be targets in lupus type membranous nephropathy, some associated with neurologic disease, the contactins. FAT1 seems to be the auto target antigen in membranous nephropathy that occurs after hematopoietic stem cell transplant. So I think we're finding this at an accelerated pace, and we're left wondering how to use them clinically. Some of defining a phenotype may be important and probably will be important. So for example, exhaustocin type membranous. If you stain a biopsy tissue and the deposits light up for the exhaustocin 1 and 2, this tends to be occur in younger females, typically in the setting of lupus or other systemic autoimmune disease. You can find secondary features, the subendothelial deposits, the mesangial deposits. But interestingly, versus other cases of type 5, class 5 lupus nephritis, there may be less chronicity and better renal outcomes clinically than someone who doesn't have this and has lupus. However, no autoantibodies have yet been found, so there's no serologic test for exhaustocin-associated membranous nephropathy. NEL1 associated membranous nephropathy does have circulating antibodies. It was initially described as a probable primary type of disease. Since then, other studies have shown many of these cases may be associated with malignancy. So you may have some primaries, some secondary. Some other clues are if you do subclass staining of IgGs, it tends to be IgG1 predominant instead of IgG4, like the rest of primary causes. And instead of a global deposits in the glomerulus, you may have a segmental to incomplete loop pattern. I didn't mention, so NEL1 is definitely would trigger a good screen for malignancy in your patient. THSD7A, and this is work by the Humber group, is also associated with malignancy, and there have been a few cases in which the tumor itself overexpresses THSD7A, and that's probably the trigger for the autoimmune response. So THSD7A and NEL1 may be associated with malignancy-associated disease. I think an intriguing find was the antibodies to semaphorin 3B. These tend to be pediatric cases of membranous nephropathy, very rare, but many of them seem to have autoantibodies to semaphorin 3B. So clinically, what are we looking at? So the top, 6 here, there are autoantibodies. I put an asterisk by semaphorin 3B because these autoantibodies don't seem to detect the native protein. They require a chemical modification, the reduction of disulfide bonds before the antibodies will react. So this may be a cryptic epitope that somehow becomes available in these patients. The only serologic tests that are clinically available are the two PLA2R tests, the Elisa and the IIFT, and then THSC7A, for which there's an IIFT is available as well. I think PLA2R testing is routine because this is the most common. We know the most about it and how to monitor levels. Many centers can get an anti-THSC7A test with a little work. Hopefully that will become easier. The rest of them aren't really clinically available, and only academic centers who do research in the area could provide that. Similarly, the biopsy stains, those that do a lot of renal pathology may be starting to do some of these specialty stains, but in general, PLA2R is routine, maybe THSC7A, and then it's worth inquiring whether this can be done for some of these other types. So this was a nice little diagram from the Kdgo controversies report in 2017, but it really breaks down primary disease, idiopathic membranous nephropathy, the bulk of which is PLA2R associated, but we're starting to find some others. The importance of defining primary disease is that these are the ones you would consider immunosuppression for, versus all these potential secondary causes, so cancers, infections with hepatitis, other things like syphilis, lupus, or other systemic autoimmune diseases, NSAIDs. There may be some markers to look for the cancer-associated membranous. NEL1 I mentioned. These three markers are for the class 5 lupus-type membranous nephropathy, but it's important to define the secondary causes because you want to treat the secondary cause first, right? If it's hepatitis B associated, you give them entecavir or some other antiviral. If it's a malignancy, you get rid of the malignancy. So making that distinction is still an important step. And there are other, if your pathologist doesn't do all these stains, there are certainly clues that will trigger sort of a more thorough search for secondary disease. So if you have a full house pattern, in addition to the IgG, you have IgA and IgM. In addition to the C3, you have C1q. That's more likely to be an autoimmune systemic disease like lupus. Similarly, if you have mesangial deposits and subendothelial deposits, think lupus. There's been one or two reports saying that infiltrating immune cells in the glomerulus may trigger a search for malignancy. Some have validated that, some studies haven't. And then tuberoreticular inclusions in the endothelium. The interferon state could be a viral infection or it could be lupus. So when I think about testing a patient, I don't do this on every patient that comes to nephrology clinic with proteinuria, right? There are a lot of diabetic patients that I would not send this test on. But I think you have to have the appropriate patient, probably a gram of protein a day or more, with some evidence that this isn't your typical secondary FSGS from obesity, nephron loss, etc. They tend to be hypoalbuminuric, have some degree of weight gain or edema, and there's really no other cause. So if you make the decision, you send the anti-PLA2R test, then you want to know, is the result you're getting, is it really positive or is it really negative? So the sensitivity of the tests comes into play, the specificity comes into play. These are very specific tests. If you truly confirm that the patient has anti-PLA2R, nearly 100% of the time they have membranous nephropathy. The question is, what is a positive test? So if you do the immunofluorescence test and you get a positive 1 to 10, 1 to 100 titer, you're guaranteed that's a positive test. If you do an ELISA and it's greater than 20 or more, in many cases that will be enough to say this patient has circulating anti-PLA2R. There's a gray zone between 2 and 20, and you'll see why in an upcoming slide, where you might want to confirm that with a more sensitive immunofluorescence test. Similarly, if you do the ELISA, you get less than 2, that's clearly negative. If you do the IIFT and it's negative, that patient does not have anti-PLA2R. In this gray zone, you want to do the IIFT, and if it's negative, then you've confirmed that that patient does not have antibodies. So this is the upcoming slide. This is a recent paper that's looking at the newer chemiluminescence assay. And I'm going to disregard this panel, but all these patients were tested, and they're primary membranous, they're secondary membranous, and many other glomerular diseases. And they were tested in all three assays. This is the ELISA we were talking about. This is the indirect immunofluorescence test. So you can see why 20 is a cutoff, right? The manufacturers chose this because it will detect most of the cases of primary membranous nephropathy, and it won't detect these lower level titers that can be found in lupus, minimal change. We see this in diabetes, IgA. But if you lowered the cutoff to 2, you'd pick up some of these and your specificity would go down. I do want to mention that there are very rare cases where an ELISA titer over 20 will occur and will not be membranous nephropathy. These have happened in diabetes. We've seen it in amyloidosis. But if you do that, so these low-level tests by the ELISA, this is the PMN group, the primary membranous group. If you do all of these by IIFT, these will convert to a positive immunofluorescence test in the membranous case, but they'll be tested negative. So you'll get rid of these false positives by combining it with an immunofluorescence test. So good, my patient tested positive, now what? As we discussed, if there's a question of secondary causes, if that patient has stage 3 CKD or higher, you probably should move on to a biopsy. But you want to think about the clinical severity of their disease. You want to think about the level of anti-PLA2R. If it's a low-level anti-PLA2R, they're subnephrotic. I think most people can wait and continue the supportive therapy with ACE inhibitors, ARBs. But you probably should follow the titer over time. And you can debate how frequent that would be. I think every 3 to 6 months might be reasonable. If you have declining titers, that patient is entering a spontaneous immunological remission and should follow with a clinical remission. If the patient has stable but low levels, I think you can continue without immunosuppressive therapy. If the levels are high and stable, that patient will likely develop disease and probably will need treatment. Similarly, if you have increasing titers, that patient's going into very active disease and will probably need treatment. So if you don't get a positive test, what does that mean? Well, if you really think this is membranous nephropathy, maybe you cut this patient super early. They don't have detectable levels, and if you check them in 3 or 4 months, maybe they will. So you can repeat it, and in rare cases, the patient will turn positive. If your lab can get other tests, anti-Thf-7a, you can test that, but more likely you'll biopsy the patient. You might find something else, right? This might be minimal change disease. You might find, and this would be lucky for the patient, membranous nephropathy with PLA2R in the deposits, which probably means that patient has already entered immunological remission. You might find membranous nephropathy, and if you can get another stain done, Thf-7a, now 1, you might diagnose that type of disease. Or you might find these secondary features, such as subendothelial deposits. Young women with what turns out to be lupus-related membranous nephropathy may not have an ANA at start. The membranous nephropathy can be the first sign of disease. So, if that appears to be a secondary cause, continue to follow ANA in the future, treat them accordingly to clinical grounds. And I think, the treatment section is coming up, and the question is, who deserves immunosuppression? And you have to weigh both the consequences of the treatment and also the consequences of not treating, right? So for the short term, you're worried about the acute effects of nephrotic syndrome. So our patient had probably renal vein thrombosis and PE, so who knows what could happen next, so you want to treat them. But you also consider the acute effects of treatment, right? You can start calcineurin inhibitors and their creatinine can get worse, they can get hypertensive. But we're really weighing this against the long-term risk of kidney decline. Sustained nephrotic syndrome can lead to end-stage kidney disease. We want to avoid that. But you also want to consider the late effects of treatment. And I think alkylating agents, which were one of the first treatments for membranous nephropathy, we're now all worried about inducing long-term malignancies, bladder malignancies, hematologic malignancies, gonadal suppression. So all these need to be weighed and discussed with the patient in terms of starting treatment. I've mentioned some of the major ones: calcineurin inhibitors, rituximab, cyclophosphamide in combination with corticosteroids. ACTH is something that's been used as a salvage therapy. It's a adrenocorticotropic hormone, has been used since the 50s to treat nephrotic syndrome. It can reduce anti-PLA2R levels, and some people are using that as a home injection therapy for their patients. But I mentioned the Toronto Membranous Nephropathy algorithm, and this was developed by Dan Catron and the group in the Toronto GN registry. And generally, it's based on risk of sustained proteinuria. And if a patient has subnephrotic, less than 4 grams, you can continue them on their supportive therapy with ACE inhibitors, diuretics, statins, and generally they'll do well. If they have 4 to 8, you give them 6 months. If you can't get them down to less than 4, then you can consider immunosuppression. Those patients that have greater than 8, those are the highest risk patients. You want to try supportive therapy, but if they're having declining renal function, if you can't get them into the lower risk groups, you want to start therapy. In 2017, Anne DeVries, a few at the Mayo Clinic, and Dick Glassick came up with a proposal for a serology-based approach to membranous nephropathy. And this was the first time that guidelines were introduced about using anti-PLA2R to diagnose, monitor, and guide treatment decisions in membranous nephropathy. And you can see in many of these cases, if the patient has high levels and they're nephrotic, or if they just have nephrotic levels, an increasing titer should trigger a consideration of starting immunosuppressive therapy. I think I would agree with these two. If the patient has non-nephrotic proteinuria, I probably would still continue to watch them and not start treatment, but they may need treatment in the future. And this leads to the Kdgo guidelines for the treatment of membranous nephropathy. Again, a practice point. Treating membranous nephropathy is a recommendation, so it's evidence supported. Many of these others are practice points. But all patients should receive supportive care, right? ACE inhibitors, angiotensin receptor blockers, and immunosuppression should be restricted to those patients who are at the highest risk. They don't recommend treating subnephrotic patients, and even if the patient is nephrotic, so practice point 3.3.3, you need at least one risk factor to be present to consider immunosuppression. So what are those? And this is I've blanked out a little bit of this, but essentially the low risk, moderate risk, high risk is the Toronto algorithm, right? Based on level of proteinuria, life-threatening considerations of worsening kidney function. And what Kdgo has added is if you're moderate risk, but you don't have a high risk one of these, you don't need to consider immunosuppression. If you have one of these, and I'm not going to go through all of them, that puts you at high risk and you should probably think about treating the patients. So under this box, we don't typically do these in the United States. These are looking at the levels of non-selective proteinuria. Is there low molecular proteinuria? Is there IgG in the urine? But I think the important thing is having anti-PLA2R as a risk factor. Kdgo uses the threshold of 50. I think that's quite arbitrary, and I would look more at the combination of clinical factors and what that antibody is doing over time. And they actually say this. If you look very closely at the figure legend, they mentioned that you should follow the antibodies over 3 to 6 month intervals, maybe more frequently if the levels are higher to begin with, but that changes the trajectory of the anti-PLA2R is likely to add to risk estimation. And if you have a disappearance of your antibodies, that should lead you to refrain from treating that patient with immunosuppression. And in terms of treatments, generally moderate risk, you treat with rituximab or calcineurin inhibitors. You could use those for higher risk, but if you're very high risk or if the patient or clinician is worried, you can add this modified Ponticelli regimen with alkylating agents and corticosteroids. That seems to work the fastest, may be appropriate for patients who are having declining renal function. So I've modified that a bit schematically. Similar agents here, but you want to take into account what's happening to the anti-PLA2R. Is it going down? Maybe wait a little longer. Is it going up? Maybe that pushes you more quickly to consider immunosuppression. And what do we use? The modified Ponticelli regimen, the alkylating agents clearly work. I think the concern is the long-term risks. So the decision really is between rituximab or cyclosporine, and this was nicely addressed a few years ago by the Mentor study, pitting rituximab against cyclosporine for treatment of membranous nephropathy. And it was designed as a non-inferiority, and at 12 months, there was 60% remission in the rituximab arm and 52% in cyclosporine. So rituximab was non-inferior. But when the study went on to 24 months, sort of after stopping the therapies, the partial and complete remissions in the rituximab arm were sustained, but you lost a lot of those in the cyclosporine arm. So rituximab became superior. And this is what we used for our patient. So he was treated with 2 1-gram doses separated by 2 weeks of rituximab. Note that we don't have any levels of anti-PLA2R until maybe 6 to 9 months later, by which point it had disappeared. Probably if we had checked in this range, we would have seen a drop and decline in PLA2R. But anti-PLA2R was gone, proteinuria was gone. We had a little bit of a scare, which almost prompted another cycle of rituximab. When the anti-PLA2R rebounded to about 14, there was a little blip in proteinuria, but serum albumin was continuing to rise. We elected to watch, and the patient eventually went into a complete remission with absence of anti-PLA2R. And this is what, the reason to monitor for anti-PLA2R is shown by this observational study from Bergamo, Italy, in the Beppe Ramuzzi and Piero Reginenti group, who looked at more than 100 patients treated with rituximab. Many of them had anti-PLA2R levels. And so you'd expect B cells to fall in all patients, and they did, irrespective of their ultimate outcome. In those patients that had a decline and disappearance of anti-PLA2R, shown in green, the 48 here, those are the ones that achieved the clinical endpoint of remission. Those that had a drop in anti-PLA2R, but it never went down to disappearing, those are the ones that did not have a remission. Now, it doesn't mean that you couldn't have treated them with a second cycle, a third cycle of rituximab, and maybe gotten to that point, but just with that single treatment, they weren't going to go into an immunologic remission, and they weren't going to go into a clinical remission. So Kdgo recognizes this and recommends monitoring the effect of your therapy, whatever you use. So if at 6 months you've gone from seropositive to seronegative, you can either stop the therapy, or if you're on a calcineurin inhibitor, taper it to off slowly. If the levels are declining, then maybe you give another cycle of rituximab. You stop the alkylating agents just due to long-term risk, and you watch, because many of those may ultimately go into a remission. If you're on a CNI, you want to recheck in 6 months. If you don't ever get rid of your anti-PLA2R, then you could give another treatment with rituximab. You could change therapies. You could add on rituximab. So I think using anti-PLA2R can tell you if your therapy is working or if you need a change or escalation of therapy. The last 2 slides, I just want to introduce, membranous nephropathy, many patients go into remission, but 25 to 30% may ultimately have a relapse years later. It's probably not worth checking anti-PLA2R in this interim, but if there's any increase, so if the patient was in complete remission and then develops a little bit of proteinuria, if they're in partial remission due to secondary FSGS or interstitial scarring, and they start having an incline, I think it's worth checking the anti-PLA2R again to see if they might need treatment. And finally, the last topic, which will be discussed by my colleague, Jean Francis, who's a transplant nephrologist, in March in this series. Membranous nephropathy can recur in the allograft. especially if anti-PLA2R antibodies are still present at the time of transplantation. So that will be a topic in itself and is also addressed by Kdco guidelines. So in summary, I hope you realize that membranous nephropathy is a group of disorders marked by specific autoantibodies and or antigens enriched in these deposits. That in the appropriate situation, you can have a serological diagnosis, a non-invasive diagnosis from PLA2R associated membranous, if you can clearly show that there are anti-PLA2R antibodies. That circulating autoantibodies, and this, we know the most with anti-PLA2R, but I think we'll start finding this with the other autoantibodies, are very useful for monitoring early immunologic activity that can guide therapy. Most importantly, those with declining levels or levels that have disappeared may not need treatment. You don't want to expose your patients to the risks of immunosuppression if they're going to go into remission anyway. We use a lot of Rituximab, but there are other agents out there, calcineurin inhibitors, and the alkylating agents are the only ones that have been shown to have 10-year renal survival. They were the oldest ones, and we know that they work. So if you're in a situation where your patient needs immediate treatment and is willing to take the risk of long-term effects, go with that. And treatment should be continued until those antibodies are undetectable. And even though it's difficult these days to get some of these other testing done, I and others are hopeful that these will become available. There will be panels available that we can categorize our patients and use precision or personalized medicine to follow and diagnose and treat them. So with that, I will stop. Thank you for your attention over the last hour or more, and will make myself available for questions.
So much, Dr. Beck, for this really insightful and wonderful presentation. I'm sure the audience would appreciate as well, would also mention the same. So we've received a lot of questions pertaining to PLA2R antibodies and their testing, the treatment, and also some general questions. So I'm going to try to cover as much as possible, depending on the time limit we have. So jumping right into the first question, is the antibody titer, I think this is referring to PLA2R antibody titer, related to the severity of the disease?
Yeah, that's a very good question. It's a difficult question, and this is why I think the levels are somewhat arbitrary. I mean, I myself, and I think others have had this experience, have had patients who go from full nephrotic syndrome to, going into remission with minimal changes. So they may be fully nephrotic at levels of, say, 40, and then, like others, if once their anti-PLA2R is under 2, will be in remission. I've had one patient who's had levels over the curve, over 1,500, who went through pregnancy that way, and she was very, very minimally nephrotic and had no problems with pregnancy. So I think there may be other factors that we don't know about, different individual sensitivities and thresholds. But in general, if you look at aggregate groups, those with the highest proteinuria will have the higher levels. But you need to take each case individually, and I think following levels may be more important to say than my patient has a titer of 72. Does that mean they're going to have bad disease or good disease? I think you just need to see what happens.
Got it. Thank you. So is the PLA2R expression in the kidney increased during membranous nephropathy?
Another good question. Let me mention that one confusing thing is that people say it's downregulated because you look at your stain and you see all the PLA2R in the deposits and you don't see anything in the cells. One reason for that is that the pathologist has titrated that commercial antibody to make it easy to see who has PLA2R in the deposits by limiting the antibody, the commercial antibody, so you only pick up the deposits and you don't see much in the cell. If you used a higher concentration, you'd probably pick it up in all the cell bodies, but then it makes it difficult to say, is this a positive case? Is this not a positive case? There's some evidence either that there's minimal change in protein expression per se at the mRNA level, or that it actually might be upregulated in individuals who are genetically predisposed. Christoph Kirlich's lab at Columbia has shown that there are enhancer elements that might be upregulated. So that itself might be a risk factor if your podocytes make more than average levels of PLA2R. But that being said, there is a dynamic, right? You're making the protein, you're shedding it into deposits, and I don't think anyone really knows if you compare a healthy podocyte to a podocyte that's making and shedding deposits, what levels are in the cells. But so complex answer. We're still working on it.
Sounds good. Thank you. All right. Next question. Is PLA2R antibody testing relevant in secondary membranous nephropathy?
That's another touchy question that I don't think people have a great answer to. You can certainly have so I guess the question is, how do you define secondary disease, right? I mean, you can have a patient that has PLA2R associated membranous nephropathy that has hepatitis. Do we know that the hepatitis B is causing it, or is it coincidental, right? The median age of onset of PLA2R is in the low 50s, and so half patients may be over that age. They may be more at risk for malignancies. Do we know that the malignancy is age-related and coincidental, or is it causing the PLA2R? So there are many studies out there that show that anti-PLA2R can be present in NSAID-related disease. Again, a lot of people use NSAIDs. How do we know that NSAIDs are causing secondary? Hepatitis C and sarcoidosis associated. This was a paper from Nephropath at the time, now Arcana Labs, Chris Larson's group. So you can find PLA2R in the deposits. You can find circulating anti-PLA2R. I think in that setting, it's worth dealing with the secondary cause, treating the viral infection. Hepatitis B, there's a Chinese study that shows that 67% of hepatitis B associated membranous may have antibodies and may show PLA2R in the deposits. I think that's still unexplained. Is the virus a trigger for an autoimmune disease? But you want to treat the secondary cause, and probably it's worth following the anti-PLA2R to see what's happening. If you have a patient with a prostate cancer who's 70 years old and you has membranous nephropathy, you check anti-PLA2R and you get a titer of 150, and you treat the prostate cancer, resection, radiotherapy, but the PLA2R antibody doesn't go down, then I think in that case, maybe this is primary disease and you should treat that patient with immunosuppression once you've dealt with the cancer. So sometimes they're unrelated. Sometimes the relationships between secondary disease and anti-PLA2R is not fully defined. Hopefully we'll figure out ways of addressing that in the future, but I would think of them as separate. And I wouldn't rule out, if you know a patient has a cause for a potential secondary, I wouldn't neglect to check anti-PLA2R, I guess I would say.
Right. Thank you. So next question, when do we consider anti-Th-7a antibodies instead of PLA2R? Additionally, would you recommend testing for both antibodies in parallel?
I think the one, it's I think easier to get anti-PLA2R testing. We are fortunate in that our send out, we don't do our own testing, has a reflex. So you could request the anti-Th-7a. It's not a full reflex if you have a negative anti-PLA2R. It is, if in primary disease, 80% is PLA2R, then 2 or 3% is Th-7a. So probably it's not worth doing that routinely. You're not going to find Th-7a a lot. So I would definitely start with the anti-PLA2R. If it's negative, then consider anti-Th-7a. A higher likelihood, once available, would be anti-NEL1 testing. Patients with malignancies, again, I said that there have been a few case reports where the malignancy actually has trisomy for the chromosome expressing THSC7A, so it was making more of the antigen. Maybe that's the trigger to the immune system. Many tumors may stain for THSC7A, so I don't think it's necessarily worth staining the tumor, but malignancy and a negative anti-PLA2R might prompt you to stain for THSC7A. Again, those rare cases, I think if you're under the assumption that you might find a rare case, in someone who's anti-PLA2R positive, again, staining everyone or testing everyone for anti-THSC7A is probably overkill, and you're not going to pick up that rare case. Staining the tissue, if your pathologist can do that, might be more cost efficient.
Thank you. Okay, this is interesting. What percentage of healthy persons harbor anti-PLA2R antibodies? Is there something distinct about disease-causing antibodies?
Another excellent question. Thank you for asking, and thank you for picking these ones. So a lot of studies have used healthy controls. The development of these ELISAs, when we were looking for who detects that band that we didn't even know was PLA2R, we never found healthy individuals with anti-PLA2R antibodies. It doesn't mean that there's some out there, non-pathogenic forms, but really we haven't found them. As I said, it's a very specific test. If you find it on the ELISA and it's confirmed on the immunofluorescence test, in virtually all cases that patient has been shown to have membranous nephropathy. Other autoimmune diseases, I think they're non-pathogenic ANCA, they're non-pathogenic anti-Gbms. Maybe we'll find those, but what is the predisposing factors? And there's a lot of genetic data that certain HLAs, the HLA DQAs and the DRBs can have predisposed to genetic risk. There may be a trigger. You may have to have that variant within the PLA2R gene that may overexpress. There's a nice study from China that shows that membranous nephropathy in cities is associated with the level of particulate air pollution. And one hypothesis is that there's inflammation within the lungs or upper airways that triggers these. PLA2R is somewhat of an innate immune response gene. So maybe you make a little more of it, maybe it gets malpresented by specific HLA molecules, and that's the trigger for autoimmunity. But in general, healthy individuals haven't been found to have this. Please let me know if you have a potential case, because we'd be happy to study them.
Thank you. Okay, coming to some specific testing questions, would you recommend IFA or ELISA for monitoring patients? There's a second part, so probably I'll wait until you respond to this first one.
I think, this is going to depend on what your center does. Certain centers only send out and get the IFA test, certain centers only get the ELISA. I think numerically it's easier to use the ELISA. There's some variability. I mean, if you take the same patient and test them and their level's 100, you test them the next hour, you might get 110. But over time, I think you can clearly see a decline or increase in PLA2R. The same thing for proteinuria, right? We don't take that as an exact UPCR of 7.2, maybe 8.6, maybe 5.3 the next day. It's quite variable. But for monitoring, ELISA is easier. Not to be said that the IFT can't be used, right? You could go from a titer of 1 to 100,000, 1 to 1,000 to 1 to 332 to. Right. So it can be done. It just whatever your lab can send.
The second part is there a correlation between the RU per mil and the titers, so ELISA versus IFA?
So there are, if you look at the graphs that have been published on this, it's semi-quantitative. The IFA titers, just the way it's done, either gives you the 1 to 10, 1 to 100, 1 to 1,000, or you get sort of in-betweens of 1 to 32, 1 to 320. So each of there is a correlation, but if you do a scatter plot on 1 to 10, you're going to have a range of ELISA titers in this scatter plot. So it's sort of this range that's going up in a semi-linear manner, but yeah.
So another similar type of question, IFA being more sensitive, are there any additional advantage to the ELISA other than from a clinical standpoint?
It's higher throughput. Many people have automated microplate readers and automated ELISA setups. The IFA is a little more subjective, and you have to look at these under the microscope. Again, there's probably some automation to this that's possible. EUROIMMUN may know more about that than me. But I think that the higher throughput, and that you can test more patient samples on a plate. The one disadvantage, and I think this is why we have some false positives, is that so the IFA I showed you has an internal control, right? You have these cells, these HEK293 cells that are just your parental cell line, and then you have those same cells transfected, and their only additional protein is PLA2R or some other antigen in another type of test. So if this patient has particularly sticky IgG, and we do see this in diabetes sometimes, you may get non-specific staining, and so you'll know if your parental 293 cell chip tests positive, and so that might clue you in that the ELISA doesn't have that. It's just PLA2R on the bottom of the plate, and it's a very good test. But in some cases, the patient just has sticky IgG, I call it. So if you tested them against a blank plate, or if you tested them against another antigen, anti-Gbm or PR3, they might also be positive just because their IgG is sticking to the side of the plate. When we've repeated those false positives on Western blot on IFA, generally they don't detect PLA2R or whatever. So again, it's easy. It gives you a quantitative titer. It's high throughput, but you just have to be wary that there's a very, very low risk that you get a false positive.
Mm-hmm. Okay. So I'm going to also switch gears a little bit and also ask some treatment related questions, just so that I'm accommodating other type of questions too before I come back. So first question here is, which forms of membranous nephropathy, primary versus secondary, can be managed by anti-CD20?
Theoretically, because membranous nephropathy is defined by subepithelial immune deposits, and IgG is made by B cells, many of them, right? Definitely primary. I think it's more of a choice of, does the patient need it? Are they immunologically active? And is that something that's available to a clinician and to the patient's insurance? In secondary disease, I think you have to think about the consequences. So if you have a hepatitis-associated membranous, yes, there are, and they're anti-Gbm or they're not. There's something that's, maybe there's just the anti-Hep B E antigen antibodies, right? So you could treat those B cells and have the B cells that are protecting the body from hepatitis B stop making those antibodies, but then what's the consequence? The hepatitis worsens, the liver disease worsens. So even though in theory you could eliminate the B cells that's making the causative antibodies, you want to treat the underlying disease first, and then consider immunosuppression. Right? Treating with rituximab can reactivate hepatitis B. So you want to be careful. Tumor immunity is important. It's more like T cell, but you want to retain some immunity. So that's why I focus on at least first treating the secondary disease.
Perfect. Thank you. Another interesting one. Does failure of anti-PLA2R decline predict treatment failure?
I think in most cases, and that was the study from the Bergamo group, that when you just had the decline, but it wasn't a persistent decrease, those were the ones that did have treatment failure, based on the immunosuppression up to that point. You can always intensify therapy if it's rituximab, give another cycle, switch therapies. If the patient's declining quickly and you want to move from rituximab to cyclophosphamide, yes, but I think we would continue to follow. And if you cannot get rid of the antibodies, I think that's a very bad sign. From all we know, these are pathogenic antibodies, and the disease will persist for the most part, as long as they're there. The speed of which, I'm sure we all have mechanisms in our kidney that make us more susceptible or less susceptible to immune complex disease, but the fact that the antibodies are still there is I think a warning sign. And theoretically, you could potentially have plasmablasts, plasma cells making anti-PLA2R. So some have considered, if rituximab isn't working, moving on to an anti-plasma cell, anti-CD38, daratumumab, to get rid of those remaining cells that anti-CD20 won't touch.
Mm-hmm. All right. Some other general questions. So are all membranous nephropathy associated antigens localized to the podocytes? Are there examples of others located elsewhere, other localizations? Yeah,
that's a great question. And one we're very actively thinking about. So there are cases where it's not a native podocyte protein. Certainly there are, we think of intrinsic antigens, and that can either be always made by the podocyte, sometimes made by the podocyte, made by others, let's say endothelial cells that sort of cross the GBM. And then there are extrinsic or planted antigens, and some people think of tumor antigens or hepatitis B antigens, or there's a pediatric form of disease that Pierre Ronco has described as anti-cationic BSA, and it seems to come from infant formula. So these are exogenous antigens that get trapped under the podocyte. But I think a very good example is NEL1. So that may be 15% of membranous nephropathy, and that doesn't seem to be made by the podocyte or by the glomerulus at baseline. So I think people are, especially given the segmental pattern of deposits, hypothesizing that maybe something triggers the podocyte into making it, or maybe some other cell. We don't know if the exostosins come circulating or are made intrinsically. And there are other proteins that haven't yet been found in the podocyte. So many of them are, but and I think we've learned a lot about podocyte biology, because we didn't know PLA2R was a podocyte antigen. We didn't know Th-7a was a podocyte antigen. HTRA1 is not specific to podocytes, but it's made by podocytes. So yeah, I think they're podocyte expressed and non-podocyte expressed.
Perfect. So are anti-Gbm antibodies important as well?
There are rare cases. So I think there are a few case series of crescentic disease with PLA2R associated membranous. So you can have concurrent disease, and that may be a susceptibility to autoimmunity. I mean, people have type 1 diabetes and membranous nephropathy, or autoimmune thyroiditis. So it may just be the genetic susceptibility in the HLA locus to having an autoimmune response to two different antigens. But in general, we don't get spreading of, interestingly, we don't get spreading if you have anti-PLA2R and you have podocyte damage. Why don't most people get anti-Th-7a? Probably related to host antigen presentation. And you don't seem to get anti-type 4 collagen antibodies or ANCAs, but they can coexist. Probably not causal, probably just a coincidental dual autoimmunity.
Mm-hmm. Thank you. So just with respect to time, I'm going to just ask another final question, and the rest of them would be addressed specifically by emails, so to those who have posted their questions. So with so much damage of podocytes and antigen-specific immune complexes being formed, would there be a membranous nephropathy signature in the urine?
Yeah, so I'm sure that there have been some studies on markers, and it's certainly a promising area. Especially you're leaking IgG. So, we and others have found anti-PLA2R in the urine. That sort of depends on the amount of proteinuria you have. But are there exosomes released by damaged podocytes that might be a better non-invasive marker, or sort of the liquid biopsy? And I think people are thinking about that. As yet, there's no clinically available test, but that's certainly reasonable. And if it could save a biopsy in our patient who was anticoagulated, and we could just do a urine test, that would be wonderful.
Perfect. Thank you so much, Dr. Beck, for this very insightful and also elaborate Q&A session that you've answered all the questions so patiently. We really appreciate it. Thank you so much for today's presentation. So with that, we conclude our first session of our autoimmune nephrology webinar series. Our next session is on March 24th. As Dr. Beck pointed out, it would be by Dr. Jean Francis on the significance of PLA2R antibody testing in a transplant patients. So please stay tuned for more information regarding that. And one last final comment, this seminar is PACE credited. So if you are interested in receiving PACE credits, please click on the link that has been pinned to the chat box, or you would receive a separate email to follow instructions to receive the PACE credits as well. With that, thank you everyone for attending today's session. I hope you all have a wonderful day. Take care. Bye-bye.
Thank you.